Welcome everybody. Call the meeting to order and call the roll.
Sure. Commissioner Chow,
Present.
Commissioner Green.
Present.
All right, I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Okay, why don't you call the items because it'll be easier on our virtual here.
Sure. Item 2 is the approval of the April 26, 2022 minutes. And Commissioner Chow offered a correction on page 2. Is it okay if I, or would you like to say it, Commissioner, or would you like me to do it?
No. Go ahead and note the area that we've asked for a possible.
No, sure. It's my error. On page 2, item 4, third paragraph, that begins with Commissioner Green asked whether goals were set too high for some metrics. The second line says Dr. Day stated that the ZSFG goals, that ZSFG was ambiguous with its goal setting and it should be ambitious. And so, please note, I will correct that when you all put through and approve it.
That's much better, Mark. Thank you.
Yeah, makes more sense.
Okay, so a motion to accept the minutes.
So moved.
And I would second it, and we need to see if there's public comment.
Yes, folks in line, if you'd like to make comment on item 2, the minutes of the April 26th meeting, please do so by pressing *3 now. I see no hands, Commissioner, so I can take your motion and second as an action,
Okay.
and we can move on to the next item, which is the Regulatory Affairs Report.
Great.
Hi, good afternoon, everyone. Hello, commissioners. So section 1, we continue to anticipate the 4 surveys that have been on the report, Joint Commission Lab and 3 CMS surveys, 2 for the long-term care and 4A, 1 for dialysis recertification. We just finished the CMS complaint validation survey, which will be on the next report. Section 2, completed surveys. We had a Joint Commission complaint lodged regarding unsafe working conditions due to a broken dumbwaiter. The response was accepted with no further action required. We also had a privacy breach, mishanded PHI to the wrong patient. It was substantiated, meaning it happened, however, no deficiencies. Plan of corrections, we have none for this report out. Open site visits, we had documents requested for a fall, which the patient sustained a fractured mandible. Fall with injury, documents were requested and the interview is still pending. Item 44, retained Penrose drain from May 2020. Documents and interview are still in the process of being requested. Item number 62, Joint Commission complaint regarding a nurse who did not check blood sugar, resulting in the patient having a hypoglycemic seizure. That was the allegation. Our response was submitted to the Joint Commission website on May 17th, and we're waiting to hear back. Item 64, patient-to-patient sexual assault. This was originally reported to CDPH. However, they deferred to the Joint Commission for review, and we have an RCA follow-up call with them scheduled for August. Section 5, new facility reported incidents. So item number 1 under this section, there was a retained foreign object regarding a wound vac sponge. So in March 2021, during the course of care, a wound vac was placed at the bedside. The patient returned in April 2022 for pain, and a piece of wound vac sponge was discovered. Risk management is working closely with trauma and their wound care teams, and the RCA is anticipated to be scheduled within a couple of weeks, so we'll have more information. Also reported was a privacy breach, unauthorized access impacting 61 patient files. An allegation of breach was reported to the privacy office. After an in-depth investigation and extension of the look-back period, it was determined that the involved staff member did not have a business need when accessing 61 patient medical records. Unusual occurrence, patient injury during transport resulting in a tibia fracture. The critical care and lift teams were transporting a patient. En route, the side rail of the bed hit a wall upon entering the elevator, and the leg was seen out of the bed and lying on the side rail. Imaging later determined a tibial fracture. An RCA was conducted on 4/22/22, and RISC is continuing to work with critical care and nursing administration on education regarding transport. Item 5, elopement and AWOL. A patient was on a legal hold, left his room with the sitter following close behind. The patient opened the door and exited down the stairwell. And the last one, patient-to-patient sexual assault in 7B. My sincerest apologies, this was not reported. Through an in-depth investigation, it was unsubstantiated. We didn't have any evidence to support the allegation, so I've removed it for the next report out. Happy to help with any questions.
Thank you. Mark, should you check public testimony?
Yes, sir. Folks on the line, if you'd like to make comment on item 3, the regulatory affairs report, please do so now by pressing *3 to raise your hand. Again, press *3 so that we can recognize you. All right, I see no hands, commissioners.
Okay, so Commissioner Green, any questions?
Yeah, I guess I know we'll get more detail about some of the new fries, but when will we get more updated on the interpreter use? I know today I just got they're actually going to do exams for staff to see if they really have fluency, and will only approve as translators those who've proven fluency. And I wondered what kind of progress we'll make or what our timetable is on that.
Thank you for that question. I've completely missed that section in the report. Thank you. My apologies. So plan of correction monitoring data. So our compliance increased from 40% to 60% for this monitoring. It looks like there was a best practice advisory reminding RNs to actually document, which has bumped up the compliance percentage for that one. And we will have more of an update on this at the next ALCC, which is scheduled actually for June.
Okay, great. Thank
Okay,
you.
and also the autopsy request completion. We're continuing to monitor. There's still challenges regarding when to sign the autopsy or request for autopsy form, if it should be completed, by the providers, or if the family calls HIMSS to follow up. So there's still some to be figured out on that one.
Do you
And
have
we're
a sense is there like a timeline for how often this comes up in what interval? As I looked at that, I was a little confused, wondering, how it takes people a while to process. Do you reach out? Is there a protocol? Is there like a deadline? I mean, there must be some kind of time frame that reflects what is typical and then what works for the system.
That's a great question. I'm happy to meet with stakeholders and find out more information about the timeline.
Thank you.
Thank you.
I had a question that you skipped item number 2 on the new facility reported, for which there was no date, but there's a large number of items from the Joint Commission. So what are those about?
Sure, great question. So there was a complaint lodged with the Joint Commission regarding staffing ratios in endoscopy. Part of the allegation was regarding the GI fellows assisting the GI attendings, whether they have adequate training to do so. And the nurses who participate in GI, they do moderate sedation as well. And there was some concerns about being pulled away from moderate sedation to help the GI fellow. So we're working to a response for that.
So what does it mean by no date? I mean, there must be a date in which we heard about it or you heard about it. So it can't just be no date, right?
Right. So actually, that's the date that the incident occurred. And in the actual allegation, they not specify a date of when this particular unit was out of ratio.
Oh, so if you don't have a date that they're talking about, how do you investigate this?
That's a great question. So we reach out to endoscopy and the leadership to see if they've even found any similar situations. Thank you. Any similar situations. We have to go by the details lodged in the complaint and investigate that way. Sometimes we can't do a thorough investigation due to lack of details. Um, Luckily, with this one, endoscopy had reached out earlier to get Title 22 staffing ratios. Some of these allegations had come up already. How are we meeting these allegations? So they're going to do, um, you know, they're going to meet with the GI fellows to make sure that they follow the training and document that way.
Okay, so this is kind of prospective. With the allegations, we don't necessarily find a fault because we don't know what days they're talking about, but we're going to see that we're in compliance with the guidelines, right?
Exactly. Yeah, sometimes we can't even substantiate an allegation due to the lack of details on what to investigate.
All right, then we'll just see how you follow up on that. Thank you.
Thank you.
I think if there are no other questions, Mark, shall we go on to the next item then?
Sure, yes, sir. Item 4 is the ZSFG Safety Strategic Improvement Plan. And Adrian, I gave you permission to share your screen, but I'm not sure who's actually doing it. Are you the person?
Yeah, it will be me. I'll do that right now.
Okay, great.
Okay. Good afternoon, commissioners. I'm here with my colleagues Leslie Safier and Lisa Winston to present an update on our Keeping Patients Safe A3. As you can see, it directly reflects our True North values, specifically safety. So when we as a team in the executive team plan and coordinate our work through Hoshin, we use the X matrix, and I don't expect for us to go through the X matrix right now, but I've put it on the screen to demonstrate that it's a lean concept, and we use this to ensure that there are alignment with each of our strategic priorities. And eventually our KPIs with True North. The work that was originally taken up in this was specifically addressing safety, and this relates to the CMS star rating. But it does also affect some of our other True North outcomes, care experience, because it was related directly to patient harm, and if a patient experiences harm, it affects their experience in the hospital. It can have an effect on the finance pillar because if a patient's length of stay is extended or there are additional care requirements based upon a harm, that can affect our reimbursement and also the amount of money it costs to treat this. And then quality, when we think about the quality of care, when we think about throughput, when we think about flow, it can have effects on all of those things. Today, what we really want to do is give you a status report of where we are in our safety A3. So the background to this is we acknowledge that minimizing patient harm is an intrinsic priority in healthcare, and that's been underpinned by value-based purchasing, which the federal government have introduced to incentivize the reduction in patient harm. In previous years, the strategic focus had been very much on harm at ZSFG, and then in FY 1920, harm events increased after we had stopped focusing primarily on those as a strategic priority. And then since then, there have been multiple competing priorities: EPIC, COVID, and then staffing and leaves have all impacted our ability to deliver this work, and it's had a direct effect on patient care. So where does that leave us today? And when we think about current conditions, if we cast our minds back, our goal was a composite goal, it encompassed it encompassed four harm event types. So those harm event types were colon surgical site infections and central line associated bloodstream infections. And we met our goal in both of those. And you can see from these graphs that through February of this year, we were meeting our goal. Our other two metrics as part of the composite metric were of course, falls with injury in specific areas of the hospital and catheter-associated UTIs or CAUTIs, specifically in ICU and med-surg. And we were not meeting our goals and targets for these falls. We had not achieved any real effect on the volumes of falls with injuries. Catheter-associated UTIs, I do want to note that we're 0.01 away from our goal of 2.26. So although we're currently have not met our goal, we're definitely very close to that. Our problem statement in our original A3 and in our A3SR is it really speaks to the 130 incidences of targeted preventable harm that patients experienced at ZSFG in the fiscal year 2021. And the work that's been done over the last 2 years have been really focused on trying to reduce that. So to really look at our targets and goals and the composite metric, this slide really shows the work that's been done and the work that. So it talks to our achievements and it talks to the things that we still continue to work on. We'll talk in a little bit about why we've been successful in some areas and not as successful in others. But I think if we look overall, we acknowledge that some of this is secondary to all of the additional pressures that healthcare has been under. But we have definitely had some great success in CLABSI and colon SSI. So our countermeasures and what did we do to try and address this? Some are in progress and some are completed. As we created our A3SR, we looked at why we hadn't achieved some of our outcomes, and we looked at what successes we'd had in achieving some of our other goals. So as we began to think about what our obstacles have been around competing priorities, around the disbanding of harm teams, and the varying use of standards and best practice. Specifically for falls, we engaged our med-surg nursing falls leader, and we've been working really closely with her on unit-specific initiatives. And the needs of the patients on many of our units are different. We have different needs in the TBI unit to the ACE unit, and then our regular med-surg patients have very different needs from the other med-surg areas. So Dana Frazier has been working really hard to ensure that those interventions that make the most difference have been implemented in those areas. And some of the things that she's been really innovative around have been things like chair alarms, toilet alarms, bed alarms, regular rounding on patients and things like that. And that continues to be in progress. When we think about CAUTI, we have the same barriers, but we've completed a number of the interventions in that. And although overall that metric is red because we've not quite met our goal at this point, we're very close. And there's been a lot of great work that's been done, especially in the ICU, with daily care and insertion training being given to all of the nurses. And I want to also acknowledge the neuroscience teams because they have extended these into the care pathways that they use for all of their patients. And this has actually been disseminated to some of the med-surg areas for the neuro patients as well. And then finally, for colon SSI, we've got some measures that are in progress and one that's completed. The completed is around standardizing wound closure and antibiotic practice. And then there are other clinical pathways and and tools that are being used in the perioperative area and in the postoperative course of the patient that continue to be in progress, but have been demonstrated to make a really great effect on our results. Achievements, and I really want to pay homage to all of the people that have worked really hard on this. We have sustained reduction in colon surgical SSI infection, and this has been really down to a multidisciplinary team approach. The fact that the teams involved in this not only participated in this strategic goal, but integrated it into their own departmental PIPS process as a driver in their own area, and through continued executive support, not just from Lisa and I, but from other executives on the team as well. The decreasing CLABSI, standardized infection ratio, is something that we should be really proud of, because the national trends have seen an increase during the COVID-19 pandemic, and that's not what we have seen here to the same volume as in other areas. And then lastly, I want to really talk about how many areas that we have been working with are embedding monitoring and action to prevent harm measures into their individual departmental PIPS drivers and their ongoing performance improvement work. And I think that Leslie Safier and her team in performance improvement have been so integral into that role and been such champions of making sure that our PIPS and our quality assurance and performance improvement program really reflects the work that we do strategically and then clinically at the bedside too. So what are we going to do next? We know that we still have work to do, and the executive team have begun the HOSHN process for strategic planning for June. And we'll be meeting in June of this year to do that. We don't want to lose sight of these specific, very granular harm metrics, even if our HOSHN doesn't focus on them individually. So defining we'll continue to monitor these through the end of this fiscal year, and then the goal of all of those 4 measures is to embed them into individual departments' PIPS drivers. And then everything that we've learned in the last 12 months and everything that we've learned through this A3SR and what we'll learn in HOSHN is going to guide the redesign of the patient safety program. I'm sure that we've talked a little bit before about how the patient safety program here at ZSFG has been a long-standing part of our quality management department. And over the last 12 months, all of the staff that were previously employed in those roles are no longer with us. So we're looking at how we can redesign and hire into those roles and make the patient safety program an homage to what's gone past and all the great work that Tom and his team did, but also making it dynamic and reflect the work that we're doing here at ZSFG. I'm going to round off the presentation there. I would love to hear questions, and either myself, Lisa, or Leslie will be able to answer any of those questions.
Thank you very much. So, Mark, let's check if there's any public comment on this presentation.
Sure. Folks on the line, we're looking at item 4, Safety Strategic Improvement Plan. If you'd like to make comment on this item, please press *3. Again, *3 to make comment on this item. I don't see any hands, commissioners.
Okay, so let's go on to see if Commissioner Green may have some comments, and I have 1 or 2 questions.
Yeah, well, I just applaud you for the progress you've made on especially things that were kind of humming a little bit below goal, especially the COWT and the colon SSI, which I know kind of hovered in a not quite where you wanted it range for quite some time. So I think I saw this, I thought this was such terrific news, and congratulate everyone for accomplishing it. I know the falls, of course, were challenging. We've talked about that. That's probably incredibly complex and quite individually driven. Given the success you've had, what are the plans to kind of codify the processes? I know, I asked the question in the email about the fact that you had really thoughtfully developed a program for the neuro ICU in particular, and apparently it's having its effect. So as staff turns over and leadership changes and things like that, it is part of your plan motion to kind of encode what's been done so that it continues to be done regardless, and that new residents in particular that come in that may have not have been aware of the work and the priorities, that they'll also be well informed.
That's such an insightful question. I really appreciate it, and it's something that we've thought a lot about, which is why we feel the value of embedding many of these measures into each department's PIPS process as a driver will keep the work active and patient focused. I think one of my big passions and what drives me to try and do my best on every day is that this organization is so patient-centered. And these 4 measures are very patient-centric. They're about things that happen to patients that we want to prevent. So having them as a strategic priority was incredibly important, and it raised the awareness of it for the whole organization. To sustain it, we need to make sure that ownership lies with the people who do the work. And I think that that's the key to move this forward. Falls is the outlier, and as we begin to redesign the patient safety program and hire into those vacant positions, Falls is going to be a big focus for us. But partnering with Dana Frazier in MedSurg and partnering with the leadership in ICU is going to be the key for that. And actually, the ED have begun to get more and more involved in how we can think about those patients, because they're unique in the fact that their length of stay in the ED is so much shorter that we don't have the time to do all of those great assessments and risk assessments around how likely to fall someone is. So the ED has very different challenges, and their leadership are very engaged, and we're looking at how we can protect patients in that area too. But yeah, to answer your question, I think the key for us is to maintain a focus on harm at executive level, but embed those specific granular details into the departments where the work happens, and that's how we'll. Sorry, I'm falling over my words. That's how we'll sustain it.
Great, because some of them are really, especially the colon SSI and the COPS, that are potentially resident linked, in that they're very involved in those aspects. The urinary catheters is more our nursing staff, and likewise the falls. But as residents turn over, how we're going to make sure they are immediately informed in the surgical subspecialties is.
Having the chairs of those departments and having it embedded into their PIPS report means that it has that longitudinal kind of presence in how PI happens in those departments. And it was a multidisciplinary team. It wasn't just the providers. It was the nursing staff in the perioperative areas and in the postoperative areas that were also involved in this. So it was really a team effort.
Well, thank you, as you always do so well at the general. And this this was very impressive. Congratulations! This is really good news.
Commissioner Shao, you were muted. I will unmute you.
Oh, okay. Thank you. I was just saying that I agree with Commissioner Green that, and in spite of all of the challenges we've had, that we've been able to actually continue to work on these, and that some of them come close to goal. I guess my first question, actually, that I was looking here on page 9 here, your targeting goals is the target tied to some sort of star or measure from the Joint Commission, or is this SFGH's own target that it is looking at?
Leslie, do you want to answer that question?
Yeah, sure. I'd be happy to answer that question. So those targets are actually our internal targets. I believe that at one point we put benchmarks, and that was really the 90th percentile. And for the majority of these conditions, with the exception of falls, it is 0. So when we look at other hospitals across the country for CMS, the Centers for Medicare and Medicaid Services, in the top 10%, many of those hospitals, which some happen to be very small and specialty hospitals, are reporting 0. That's often the benchmark. Really, what we're striving for is 0 harm. But we did, I believe, about a 20% reduction from our baseline, and that's how we set our internal goals.
Okay, so I think the one that is probably the one that has the most, at least public attention, is on falls. Where do we stand on falls throughout? And it's always a challenge between complex hospitals and less complex or smaller hospitals. But in that case, then how far off from, say, the 90 percentile are we?
I'm happy to start with that one, Leslie, and then you can add. Dr. Chow, I think the answer to that question is that we really, really wish we knew, because unfortunately, there are essentially no benchmarks or data from comparable institutions or other institutions to really know uh, what rate would be common, and how we might compare ourselves to other places, and that has been a significant challenge. Because for our other harm metrics, in addition to having internal standards, we can also look to see how we're doing compared to other places. So we continue to look for those, as well as continuing to look for best practices that other places have used to reduce their fall rates. But it is, in terms of data, it's really sadly lacking. So we are doing our best to compare to where we were previously.
Okay, so that's of course different than the skilled nursing facilities, which actually has a national fall rate that we can follow through Laguna. And as Adrian knows, it's actually quite remarkable. It does as well as it does. But we're saying that here in our setting here as an acute hospital, we're using the internal numbers, which are quite aggressive compared to, I guess, the results of 2021, which is, I know we've been talking about these going up. So obviously they did go up, and trying to get them back to even where the baseline was, I could see that. And thank you for letting me know that these are internal targets. I do like the idea of embedding these metrics into the responsible departments, and I guess the thing that we must not allow to happen is that they get buried there, and then we kind of all forget them, because they are important measures, as you have all pointed out, for falls and I mean for patient safety, and you've done well on 2, nearly 3 of these, and falls remains the discussion that we've had for, I guess, a good number of years. So we'll continue to do that. As we do that, I was intrigued by the thought that you're going to reorient the patient safety program. So if we're not following measures, what is your vision that you're, you know, I'm not sure whether you call it a matrix or whatever you finally come out with. I mean, is it going to really target more on customer service, or is it going to be more focused on other than clinical criteria, or what do you mean by this reorientation of patient safety?
Thank you for that question. Patient safety is there are national definitions around patient safety, and those talk about studying the harm events that happen in your own institution and addressing and designing performance improvement to reduce the risk of those harms. So we know that there are global harms that happen everywhere, but a really evidence-based patient safety program uses its own organization's data to study that, which is why one of the big focuses of the patient safety team up until last year was around falls and defining the level of injury following a fall and investigating and following up on falls. So falls will remain a big focus of our patient safety program, I'm sure. What I'm really interested in doing as the appointed patient safety officer for ZSFG is embedding patient safety into all of the work that not only quality management does, but also the departments out there that are patient facing. So my aim as we hire into those vacant positions and as we redesign that is to partner with nursing, is to partner with the providers, is to partner with the other patient safety, patient facing departments and begin to understand what their challenges are in preventing avoidable patient harm, so that we can then work collaboratively with them with executive level focus at where our highest risks are.
Okay, and when do you think that this study is going to be complete? It sounded like you thought in the coming quarter, 3 months, 4 months. We're now into May. End of May. So I guess we're really nearly the end of the quarter coming up.
So I'll have a structure by the end of the quarter. My aim is to have a structure by the end of June. And we're actively recruiting into the vacant positions so we can then begin to do the work once the structure's been defined.
Oh, very good. So I guess we, in the following quarter, would be able to understand which way you're going. Is that right?
That's right. And, I also want to mention that there also is recruitment going on for a patient safety nurse, or a patient and resident safety nurse at Laguna Honda. Nazanin and I are both the patient safety officers for our relevant organizations and hospitals, and we're rebuilding the program here at ZSFG, and Nazanin is building the program there at Laguna Honda, and this is one of the things around the centralization of quality management where our two programs are going to be aligned. There'll be unique and different pieces to the two programs because of the differences between Laguna Honda and ZSFG, but the underlying concept of patient safety and studying our own data around harm and then designing performance improvement based upon our own observations is going to be integral to the work that Nazanin and I will do to move this forward at both hospitals.
I think that sounds exciting, and the ability to really use similar approaches that will make it a system-wide program for our two hospitals. I think is very commendable, and we'll look forward to seeing how these work. Since Dr. Green and I get to see it on the other end too, right, at our other institution. So thank you again for the very fine work you're doing. We'll look forward to the results of this new patient safety program. And I think then we can go on to our next item, please.
Thank you, Dr. Chow.
Thank you, everyone who presented. Item 5 is the ZSFG Chief Executive Officer's Report and Emergency Department Newsletter.
Good afternoon, Commissioners. Susan Ehrlich here with you today. So I thought I would, as usual, highlight areas of the written report and then also highlight areas in the data. And I will specifically address the questions that you asked about the report, Commissioner Green. So first of all, as I was reflecting about this very brief COVID summary here, I think it's a perfect demonstration of this sixth surge that we're in. And that is that we give an update here about loosening of restrictions at the hospital, while at the same time we are in the middle of a surge. And I think that's reflective of kind of the general things that are going on in society right now. We have a surge going on, and at the same time, we're really we don't have the same kind of restrictions that we had much earlier in the pandemic. And so we'll talk a little bit about that. But here at the hospital, we still, obviously we're still masking. We are still working under restrictions that the rest of the world is not working under right now. So we'll talk a little bit more about that. The Equity Seeds grant program, I wanted to call to your attention. It is one of the many ways that we are promoting equity here at ZSFG. I'm very proud of this. Here you have the example of 4M promoting productive and respectful communications related to equity. I can't think of a better thing for people to be doing right now at this time in the world than promoting this type of respectful engagement around the topic of equity. So I really want to congratulate them for doing that work. Item number 4 calls out Nursing Week, which we have celebrated this month. We had a lot of opportunity to thank our nurses. Our foundation took some beautiful photographs of them, which you will see in this report and also in the ED report. But just really want to call out how grateful we are for the support of nurses. No matter what they do here, and there are many, many things that nurses do. Nurses represent about 1/3 of our DPH workforce in every area of the hospital, both line staff and leadership. And we couldn't get through any day without our nurses, and particularly over this past 2.5 years of the pandemic, they've just been such a critical asset to us. So wanted to make that point. Okay, moving on to the data, unless you have any questions about the narratives that I've submitted to you this month.
I was just wondering, I know that we've certainly honored appropriately Dr. Carlisle, but I think I noted that Dr. Elena Fuentes Affleck is not on today's call, and I could understand that having just been appointed, perhaps she's not there, but I'm hoping that she knows that she is not only welcome, but really a important asset to this committee. So.
Oh yes, absolutely. And I didn't skip over that number because we didn't think that was true. Dr. Fuentes Affleck is in her new role. She was at our executive team meeting yesterday. She's already started to contribute in really important ways. I don't know why she's not here today, but I'm sure she'll be attending in the future. So thank you for mentioning her, and we are so happy to have her on board. She's already a great partner.
Okay, great. Okay, yeah, because I want people to feel that not only do we feel that we want to welcome them, but they are an important asset to the work, I think, of this joint committee. Thank you.
Absolutely.
My other question was related to the fact that our chief nursing officer is also working over at Laguna. So how has that affected your ability to be able to continue work, the great work that our nursing staff is doing here?
Okay, so let me just pause for a moment and talk about how we're working with Laguna Honda more globally. And I'll just start by saying that Laguna's success is our success. And we have been very deeply engaged in helping them recertify. We have also been very engaged in them around discharges. Commissioner Green, this was a topic that you were interested in, and I'll say more about that. But not only is Terry deployed to Laguna as our acting chief nursing officer, but we also have there our chief communications officer, Christine Falvey. Ayanna Johnson, our chief experience officer, has been there with Dr. Jeff Critchfield developing a plan, a strategic plan for staff engagement. Our quality team, as just mentioned, has been providing consultation to Laguna Honda. And I think that will not be the end of it. we stand ready to help Laguna in whatever way they need our assistance. Does that have an impact on our operations? Yes, it does. It's hard to, have our leaders absent for any period of time as they are, not just for them personally, because it's a lot to do what they're doing, but it also then puts more pressure on those of us who are here to, make sure that the hospital is providing the highest quality care and the best patient experience, and so on. Terry and we are blessed with a remarkable group of nursing directors, and Jillian Otway and Christina Bloom are sharing in the leadership responsibility that Terry has opened for them. Jillian, of course, is our nursing director of maternal child health, and Christina is our nursing director of critical care. And they're doing a great job supporting nursing leadership and nursing in general here. So you asked a specific question about nursing, and we are very grateful for the bench of nursing leadership we have here to cover Terry, and our assistance to Laguna goes beyond that.
Well, good. Thank you. I'm reassured. And I think that it is really wonderful that you're able to share the expertise that you have with Laguna, and that the operation really is an important function. Well, I should say the Laguna is, as you say, a very important element to our whole network, and to see everybody pulling together and working on their behalf at this point. I'm sure that as we go on and come out of that, that there will continue to be increased collaboration and cooperation between our network facilities. So really appreciate your won't say generosity, because I'm sure it was with some trepidation that you're losing part of your management leadership. But I think the idea that we're all working together for the whole is really important, and I think that's a very important element that has occurred, that we're not competing institutions, but that we're actually complementary institutions, and just having similar people working and creating similar types of even monitoring and the benchmarks, and all obviously suited to each of the different facilities, is I think going to be very helpful. So thank you very much.
Absolutely. And as you say, we are indeed complementary institutions. And I think, Dr. Chow, we never like to let a good crisis go to waste. And I think if there is any benefit to the circumstance we're in, it would be that this is bringing the network closer together to help not just Laguna, but help all the patients we serve in the best way we can. And again, I'll talk a little bit more about that, the care coordination work we're doing together when we get to that part of the data report.
Dr. Ehrlich, I want to make sure Dr. Green doesn't have any comments or questions, because Commissioner Chow jumped in. Commissioner Green, anything to offer on the narrative?
Oh, thank you for asking. I think probably when we get to the data, we'll get some more. I mean, my biggest concern was the flow of patients with Laguna not taking new admissions, and how we're going to balance all that given, SNF capacity on campus, and what the workaround is going to be while we're working our way through this process.
Absolutely. There are a lot of us with that same concern, and the top line is that we are working together very closely to make sure that we are facing this challenge in the most efficient and effective way. So more on that. With respect to the COVID data, again, calling your attention to this first chart, which is a really beautiful representation of, it doesn't show fully the 6 surges that we have had, because the first surge is really off the page, and the 6th surge isn't really very well represented yet in the data. But I can share with you that we are indeed in surge number 6. Today, we have 15 COVID positive patients in the hospital. So you can see already, since we published this, it's gone up quite a bit. 2 of those patients are in the ICU. So there's not a large share of critically ill patients. And as we've discussed pretty extensively, there are none of these patients are admitted with just a standard COVID pneumonia. They all have something else going on in addition to COVID, which is another, I think, interesting feature of this surge. The impact on us, like the last surge, is a lot on our workforce. It is more widespread, this surge, across both our nursing and provider staff. So that is a new and different feature of this surge. And it does impact our ability to staff beds completely to some degree. There are other things impacting our ability to staff, which I'll go into, but it certainly doesn't help. So that's some of the interesting part of this 6th surge, which of course we haven't seen the end of yet. And there'll be more to report on later. Moving to the emergency department. So as you see, well, you don't see this here, but the emergency department, I think right now is uniquely impacted by a high level of vacancies in our experienced positions. And I know I saw Karen here briefly. I think she'll talk more about that in her report. But so that has impacted our volume. I think our volume would be higher were it not for the fact that we have fewer staff in the ED, which basically we approach by closing beds. And that the impact of that then is reflected in the report later on. We want to make sure that the emergency department environment is, that we're staffing it appropriately at our state mandated ratios. And so that's a really important goal here. So we close beds, which results in a fairly high rate of diversion, which you'll also see. But we do that in the interest of providing, the safest care that we possibly can. Following from, a relatively stable level amount of volume in the emergency department, we have a stable number of admissions. And you'll see that our leave without being seen and triage and our diversion rates are much higher than we'd like to see. Again, our standard for leave without being seen is 2%. That's the industry standard. We are above that because our volumes are high. And our diversion is higher. So yesterday, our diversion was 85%, which we, is not a number that we would like to see. But again, it results from our challenges with staffing right now, which I'm sure we will be able to address in the future. But part of it is, the healthcare workforce in general, and it's most acutely felt in the emergency department right now. On the bright side, the urgent care clinic has just been an incredible partner to help take some of the load off the emergency department. So the average daily encounters, I know we've talked about this, but they're actually really understated because the weekend volume is much lower than the volume during the week. So to that point, yesterday, the urgent care clinic saw 148 people, 41 of whom were from the emergency department. So I just can't say enough about how that clinic over time, and you can see the rise in encounters, has been such a critical piece of us making sure that the patients are seen in the right place with the right care at the right time. So I really want to appreciate what they're doing. And you can see that the transfers from the ED to the urgent care clinic, even though they're understated, as I mentioned, are about twice what we see in the other direction. So that's really important to note. There's not a lot of change in the circumstance that we have with PES and the inpatient unit. We're quite constrained in the number of acute care beds on the inpatient side that we're running because patients are waiting. We've talked about that circumstance a lot. And we are working very closely with Dr. Cunnins and her team, her growing team, to make sure that we are able to utilize the new resources that they're bringing online in the community, which is great. The other thing I wanted to call to your attention here is the maternal and child health average daily census. So we know that we're having a boom in births in the United States and locally, and we're seeing that in our birthing unit, which is fantastic. We have been wanting to grow the volume there. We're having some challenges staffing there as well. But again, we expect that those will resolve with over time, and we're really delighted to see that more women are delivering at our institution. Okay, so getting to the med-surg lower level of care, and here is where it's obvious that those numbers are going up. They're concerning. Today we have 40 lower level of care patients waiting in the med-surg unit, and about half of those are waiting for skilled nursing facility beds. So we've definitely seen not a precipitous, but a gradual rise in lower level of care days, particularly with skilled nursing, although we also see this people waiting for residential care facilities as well. There's quite a variety of what patients are waiting for. What I wanted to mention is that over the past few weeks, the department and the network have brought together a group that is chaired by Claire Horton and supported by Greg Wagner and I, and including people from our Department of Care Coordination, from Laguna Honda. Dr. Hathaway sits on this committee. We have Dr. Jim Marks to help us with data and other resources as needed. But the goal of this group is to monitor the flow out of Laguna, out of ZSFG, and to make sure that we are not competing for the same beds. So the idea is transparency of data, focusing on trends, and just making sure that we understand how the flow is going to work. It's early in the process. And as you know, Laguna hasn't started discharging a lot of patients yet. We expect that, and we are going to be working with them and not competing with them to access the limited skilled nursing facility resources that are available, not just in our community, but farther afield, because that's likely what's going to be necessary. So I'll just pause there for a minute, Commissioner Green, to see what questions you have about that.
Well, no, I mean, you guys are terrific, and it makes a lot of sense, and it's just great to hear that such great minds are working on this really challenging conundrum we're facing here.
Thank you. I also wanted to give a big shout out to our occupational health team. Dr. Hewen is here. I will just say that Dr. Hewen today was awarded the Professional Altruism Award from the Department of Medicine for his work with the OC Health team. And I couldn't agree more with the award that has been bestowed upon him and the work that he's done with the entire team. I mean, it really is truly remarkable. There are 233 employees in the DPH who are under occupational health management today. 132 of them are in isolation, meaning that they have COVID. 92 are in the high-risk testing group, so they're likely at work, but they're testing to be there, and 2 in quarantine. So, we're nowhere near where we were, earlier in the year, in the beginning of the year, when we had just the giant Omicron surge. But it's a significant number of people, and it makes it harder to staff in the hospital. There's just no two ways about that. But I couldn't be more confident in our OC Health team about the way they manage these circumstances, and that they're taking care of people who need to be taken care of, and getting people back to work as safely and quickly as can be done, with all the modern standards in mind. So I just want to really give a big shout out to them. And with that, I will stop and respond to any questions, or invite any member of my team to chime in if I've missed something or misstated something.
Mark, should we look for public comment, please?
Yes, sir. So folks online, if you'd like to make comment on item 5, the CEO report, please press *3 now so we can recognize you. Again, let's see. We've got one hand. So again, raise your hand by pressing *3. Okay, person on the line, I am going to put 3 minutes on the clock. Caller, please let us know that you're there.
Yes, I'm here.
Okay, great. I'm going to start 3 minutes, and when the buzzer goes off, please know that your time is up.
Thank you.
You may begin.
Good afternoon, commissioners and the others. My name is Lily. I'm a nurse for the emergency department at SF General. I appreciate the number, and we live it every day, so we see those numbers, right? We see the high diversion rate of 85% plus. We see the fact that we cannot transfer patients out to other nearby hospitals because they require a level of care that only SF General can provide. We see it in the fact that Pod B and C, which represent more than half of the emergency department, are closed almost daily. And to that end, the emergency department have not only a hiring issue, we have a huge retention issue. And I call on the health commissioner and the board of supervisors, as well as the management from DPH, to really look at the reason why. Why are we not able to retain and recruit so many experienced nurses to the emergency department? And only you guys can figure that out. We can only see that we are short-staffed. So when we hear numbers like preventable harm with an internal goal of less than 5%, that's all and great, but that is also still very, very high. That vision should be 0. And here's why. I mean, those problems are really secondary to staffing problems, not having enough staff. So when we have no breaks because we're working 12 hours and we're expected to break each other, well, all of a sudden one nurse has upwards of 8 patients. And when they have 8 patients, things like checking sugars are missed. Things like, wrong medications are given. And that is a very dangerous place to be at. Not only is our nursing license at stake, the hospital's credentials are at stake. And that's what I would like to call upon, as much as, and again, I appreciate all these various reports, but we actually need to see less lip service and more action. And we are calling on you guys to help us do that. Thank you so much.
Thank you.
That's the only comment that we had.
It's the only comment. Okay, very good and very pertinent. Commissioner Green.
Yeah, I had one simple question. I know UC has been on diversion and obstetrics quite a bit, and I wondered what the status is of these patients being diverted to the general rather than to other institutions. I know Kaiser and UC, what you said about the birth rate, had been on diversion, and it seemed like an opportunity. When we had Kaiser diverted to CPMC, it was a very positive experience, I think, for the hospital in terms of the bottom line, and the patients were very well cared for at Kaiser, so it was really very seamless. The communication was good, and I'm wondering where we stand on that.
Sorry, thank you for that question, Commissioner Green. I know we are rarely on telephone divert here at ZSFG, that our capacity is so, so impacted that we can't accept patients. How often we are accepting patients from other facilities, I don't know off the top of my head, and I'm happy to get that information for you.
It might be an opportunity, especially to keep those numbers up, in the area. And then the only other thing I would say is when I was just beyond impressed by the occupational health report, how you have managed to care for all of these individuals and do it so thoughtfully is just really remarkable. The numbers were just astonishing how you've been able to manage that. So kudos to you. This is pretty impressive, very impressive.
Thank you. We'll get those numbers to you.
Yeah, I agree that looking at the occupational health work there is very impressive, and I'm not sure I've seen something like that in other facilities, and certainly the detail and the carefulness of following everybody. So again, our thanks to the team too for doing that. You had a report on workplace violence, And I noted that actually in the last, it almost looks like about 8 months, there's a distinct lowering of the number of cases. So do you attribute that to some active, positive work that's been done as versus going back from July back to May of 20, where the number of cases were definitely much higher?
Yeah, I'd like to address this at a very high level, and then I see Adrian has turned on his camera. Just in general, we have put a massive amount of effort into this topic over the past 2 years, as you know. I hesitate to talk about trends here because I know that both in these data and any workplace violence data that's reported in any hospital, it's hard to say that it's perfectly accurate. And the reason that's true is because these data depend on people reporting incidents of violence, both physical and verbal. And we know that underreporting happens. It's kind of an industry standard that it's underreported. That being said, we do see a trend downward in these data that are reported. And I would say that there are multiple things that we're doing, primarily focused on de-escalation of violence and doing root cause analyses of violent events when they occur, whether they be physical or verbal or whatever. On the side of de-escalation, one of the most prominent ways that we've done that is through our BERT team, and we've given you some information about that team. It's been really successful. Anecdotally, we see reports of the BERT team every month. They are not just rounding more hours of the day and in more areas, but they're also responding to events that they keep statistics about. So that has been really great to see. And even just rounding in the emergency department, I've heard great testimony about them coming from the nursing staff and the physician staff there. So that's great. I'll turn it over to Andrea and Adrian to talk about our assault governance committee and the work we're doing there, because that's really in the that's in the responding to events category. What do we do to analyze when events have happened, and then what kind of countermeasures do we put in place?
Thanks, Susan. Commissioners, thank you. So for our assault governance meetings, we are focused on physical assaults. And basically, we have an algorithm that we use to determine whether it's high or moderate. And then we capture that information within that algorithm and work closely with the department heads on responses to mitigate it. And we have PES as one of our success stories where learning from them and activating resources to support, we've actually seen a great decline in the physical assaults. As of today, we did not have any. We meet every Tuesday at noon. And today, PES, I'm happy to say that they're doing exceptionally well in that regard. The ED, they have done an enormous amount of work creating Code 50 and such, and we've learned a lot from the ED actually, where with those lessons learned, we've been able to identify resources to support other areas in that regard. Adrian, do you have anything else you'd like to say about that?
Yeah, thank you, Andrea. You did a really great summary of the work that we do, and it's super important that we do it in real time, which is why we always meet every week. Even if we have no events to review, we meet and touch base with the stakeholders. I really want to say that I think that a huge part of the success of the assault governance team is that we have such fantastic multidisciplinary involvement. We have a leader from nursing, and we have a leader from the providers, from the two key areas, from the ED and from psychiatry, and they Kathy Balloon-McLeary, Dave Stakonis, and Malini Singh they've just been instrumental in sharing knowledge and being humble and being very open to analysing and admitting where they have opportunities and then addressing them. So, I echo Susan's thoughts that the data is only as good as the people that tell us what's happening, and we know that we don't hear about every event, so the data is not perfect. But the assault governance team, I truly believe, has made a difference in PES and the ED, and I think that is just a testament to the leadership and the frontline staff who have engaged with their leaders to make change in real time and to reflect on each event as it's happened and learn and adapt and begin to do things differently if that's been the thing that can happen in that area. And I can't say enough about BERT. I cannot say enough about the leadership of the BERT team and the difference that they have made. Their data is phenomenal, and their presence has definitely made a huge difference to how people feel. And just being safe at work is so important, and they're making a huge difference to the work that we do at ZSFG.
Thank you. It's good actually to hear that this is working as well, recognizing that obviously the data is soft in the sense that not everything gets reported. And however, at least it's a very nice trend. Dr. Ehrlich, I think our caller actually brought up a good point as we're looking at recruiting. Have we had challenges in retention?
So the numbers that we've looked at for retention are no different or better than industry standards these days. It is true that turnover is higher in our higher skilled areas, namely the emergency department and critical care. It is a very challenging time to recruit nurses these days. It's also a challenging time to get access to registry to fill behind nurses, more so than it's been in other times. Again, because of the issues with the healthcare workforce. Our strategy to ensure that we have enough nurses who are more likely to stay with us is to increase the size and frequency of our training programs. We are doing that in every area of the hospital. Basically, our goal now is to have continuous training programs. So training programs will basically take a cohort of nurses. Our goal is up to 10. We'll be up to 10 in the emergency department. Heretofore, we've had 6 to 8. And what we're doing with that generally is taking nurses who don't, at the time we recruit them, have the skills necessary to work in the emergency department, for example, but we bring them through a mentor training program for 3 or 4 months. And then at the end of that time, they're ready to work in the emergency department. Our experience with these programs is that they are really the best ticket we have to making sure we have nurses who are well-trained and wanting to stay with us. We got behind with training programs during the pandemic because we stopped running them. So basically for a couple of years, we didn't have training programs, and that really put us in a bad place, especially given the larger forces in the healthcare workforce. We are always looking for experienced nurses. That has proven to be a really tough challenge. And, again, Karen Hill can talk more about what our strategies are to bring in experienced nurses. But I think, we really feel over the long term that the training programs is where we're going to best have success with hiring and keeping nurses.
Thank you. Do we have any other questions, Dr. Green, anything, or anybody else want to add anything to the report from the CEO?
I guess I have one additional question, which is, are there any concerns at all about filling training programs? I know that many applicants are out there for nursing schools, but there are only so many in this vicinity. And I wondered if given the competition, there is any concern about being able to fill these programs?
I apologize that we don't have our nursing leaders on the call today.
That's fine.
But because they could answer this question more precisely. In general, the answer to that question is no. And part of the reason for that is because we are very often moving people from med-surg into critical care and ED training programs. So they're already with us. Now that presents a problem, of course, for med-surg. So we have to be mindful of that loop, right? But in general, no. You know, we haven't had trouble filling our training programs. Maybe one or two of the slots, but not overall in the big picture way. Again, I'm happy to provide more information for you from our nursing leaders at a subsequent report.
And is there any way to kind of think through or be able to reconfigure some of the job descriptions to make the resource, at the top of its license, so to speak, in terms of nurses? In other words, I know there's probably very well-defined restrictions of what you can and can't do in an ED, but it's a universal problem throughout the state. And is there any movement there?
I think we do. I'm sorry, I didn't mean to.
Oh, no, I muted myself by mistake. Just to rethink staffing or how certain jobs might be allocated differently.
I think we do a pretty good job in the ED now of staffing diversely, right? I mean, we don't just have registered nurses in the emergency department. We have medical assistants who provide a really critically important role there. We have social workers. We have advanced practice nurses. I will say that we are in the process of updating our minimum qualifications. And again, Karen can speak more about this because we know we're a little bit behind in how current those are for all of our specialty areas. So I know that Human Resources has been working with our team to update those, which may make it easier to recruit into those jobs.
Great. Yeah, thank you so much.
Good. If we have no other comments, then we can proceed to our next item, please, Mark.
Sure. Thank you, Dr. Ehrlich. Item 6 is the ZSFG hiring and vacancy report.
Can you all hear me okay?
Yeah.
Yes? Okay.
We can hear you.
Yeah, thank you, commissioners. I'm actually, two have been deployed to Laguna, but I'm also have worked 14 days straight, so I took a couple of days off. But I'm calling in for this this meeting today and do a VHR report out. So excuse my background. So I have the report. You have the report in front of you, but it's a couple of key things I wanted to point out in the report. And it's a couple of items that have been mentioned from Dr. Ehrlich's report, as well as questions that have come up from Commissioner Green and Commissioner Child. But I did want to point out the vacancy. Our vacancy has increased in the last month, up from 9.46 to 10.19 in the past month. And although we were successful in hiring 47 employees in the past month, but we also lost 36 in the same month, which we only met at 11 in the last month. And so out of the 36 separations, there was 20 of those were RN that separated. So, which is, concerning, but it actually has been somewhat of a pattern, a mixture of, increase in turnover, as well as this is retirement season. And so we are expecting those numbers to increase between the next couple of months, between this month and probably through the summer months. And so on more of a positive note, we do have, the vacancies that we're still trying to address, the training programs we're still trying to address. However, we have successfully hired into our ED training class the last month, and they started in June, and our next scheduled training class for ED will begin in August, and we're hoping to have at least 10 in that training class in August. ICU hired 4, I want to say 5 ICU to start in their training class, which is scheduled for next month, June 13th, as well as we have a hiring event that we're hosting next week. And that will be for 3 days, May 31st, June 1st, and June 4th. And the goal there is to address the 59, as of yesterday, we have close to about 59 vacancies DPH-wide. And a good 36 of those are at Zuckerberg. And so our goal is to try to transition as many of those vacancies and make offers to our per diem. And so those were our experience where we're targeting some of our experienced nurses and hoping to make direct offers to the per diems into benefited positions. And so we're actually gearing towards, we're targeting 1 day focused just on per diems, which is May 31st, which is the first day. We have reached out to over 500 per diems. You know, the number of responses is not as high as we wanted, but we have received maybe about 80 that expressed interest, but out of the 80, close to 40 have actually applied to the benefited position. We did reach back out to the remaining that did not respond over the past 2 weeks. We called, we texted, we emailed, encouraging them to apply as well, not only to apply and have their applications in, but also inviting them to the 1 day event, you know, focusing on them as per diems and making direct offers to them next week on the 31st. In addition to that 1 day on the 31st, the June 1st date is going to be geared towards all the applicants in the experience pool. So our plan is to do interviews during that day. And this is, again, not just for Zuckerberg, for all of our vacancies, but we're doing interviews, conducting interviews on those days and making direct offers on those days as well. And for those who couldn't make it on the 31st and the 1st, we're going to have a weekend day, which is June 4th, to continue to extend offers to per diems and to the experience pool. So that's our goal, to reach out to the experience pool and address the remaining vacancies that we have. As far as the grads and the training program, working with Jillian and Terry before Terry was deployed, but there's a group of very large group of nursing students that they want to target for their training program. And these students are scheduled to graduate this month if they haven't already. And by the time they get their board, we're hoping to have another event similar to what we're having now, but have it later in the summer, around August, September, so we can target those new grads into the training program. And as Dr. Ehrlich has just mentioned, we want to have regular and ongoing training programs, and we want to use that dedicated pool and start targeting those grads to apply to our training program, and then having regular onboarding events to make selections and have reoccurring training programs. And to go into the MQs, if we start the training program now, it will help the new grads to qualify for our MQs into the experience positions, because once we complete our job analysis, it's going to be, I won't say it's going to be more difficult, but the MQs will be aligned towards the rest of the industry, because right now our MQs don't align, which actually for some of our grads, it allows them to qualify a bit easier. But if we start our training program earlier than the completion of our job analysis, those grads will flow right into the qualified pool for our experience. So we should have a plan and not have a gap when we do complete our job analysis. And I think that was it as far as some of the questions that you had regarding the training program and the recruitment and the MQ. But if there's any other questions that you have regarding the data that was provided or any information I reported out, I'm available to answer questions.
Thank you so much for participating today. And as you can see, it was an important topic of interest. Mark, let's look for public comment.
Sure. Folks on the line, if you'd like to make comment on item 6, the hiring and vacancy report, please press *3. So we can recognize you again, *3. I do not see any hands, commissioners.
Thank you, Commissioner Green.
Gosh, Karen, thank you for your service. My God, 14 straight days for that. And you're so eloquent just then. I mean, it's impressive, all of the avenues you've considered to try to address this issue of vacancy. And I have nothing but praise for the work you're doing and hope that things slow down. You're doing an internship. Stop.
Was that it, Commissioner Green?
Yeah, no, I'm just impressed by this effort and that everyone's making and how hard everyone's working. So
I had circled also the of course the continuation of the nursing shortages, but I think we've certainly discussed that. Unless you had more to add to it, I was curious in a future. I would say a future presentation, if you could describe perhaps what each of the topics that you, well, I should say, each of the reasons you put under notes, just to sort of understand what pending announcement is different from pending requisition approval, different from interviews in progress. Of course, that one, I guess we understand what's going on. But perhaps it could tell us a time frame about what it meant. I mean, one I think does mean that you haven't got a rec for it, I guess, and another might be that you're waiting for an announcement, and maybe you could tell us how long those announcements are, pending selection, just so that we had a framework around what the notes were trying to tell us. I'm sure we've gone through that before, but it might be good as a refresher just to understand this is, a 1 week process. This is a 2 week process or whatever it is. So it would be, I think, helpful to be able to perhaps once look at the definitions of the notes.
Okay.
Okay. So thank you very much. If we have no other questions, we can move on to our next item, Mark.
Yes, and Ms. Hill, we hope you get rest. And
yes, and thank you for making the effort to be here.
Yeah. Item 7 is the medical staff report.
Hello, good afternoon, commissioners. It's my pleasure to present the medical staff report. We do not have any action items for today, so I'm just going to briefly present 3 informational items and see if you have any questions. I think you received the first 2 informational items. So we were really delighted to welcome, as you already know, our new Vice Dean of UCSF at ZSFG, Dr. Elena Fuentes Affleck, formerly Chief of the Pediatrics Service. Dr. Chow, I believe the reason that she's not here today is that she is out of the office, but I'm sure she is looking forward to joining. And she has been a longstanding and amazing colleague, and so I think we're all just thrilled that she has taken on this role. She has some very big shoes to fill. So we were also really pleased to have some opportunities to celebrate our retiring Vice Dean, Sue Carlisle, and we hope we will see her back occasionally for some encore appearances, depending on her schedule. So since Dr. Fuentes Affleck is now our Vice Dean, an interim chief of the pediatrics service has been appointed in accordance with the bylaws, in conjunction with Dr. Ehrlich, and with the chair of the Department of Pediatrics at UCSF, Dr. Shanul Jane Sean, was appointed. She is a wonderful and experienced faculty member, and we think she will be a great addition while the search is going on for the permanent chief of pediatrics. And that will probably be starting in the next couple of months. So we'll look forward to updating you on the progress of that search. And then the last thing I just wanted to mention, which isn't on your paper, but we're just very pleased, Dr. Chow, that you will again be joining us at our annual medical staff meeting on Wednesday, June 1st, virtually, as the meeting is going to be virtual. So we look forward to your comments at that time. So happy to take any questions or comments.
Mark, let's look for public comment.
Yes, sir. Folks on the line, if you'd like to make comment on the medical staff report, item 7, please press *3 now. *3. No hands, commissioners.
Thank you. I'm surprised that we don't have a bigger packet. And, did you not have a extensive MEC meeting, or it was to congratulate Dr. Wendy's athlete? Or
we've actually had some very detailed and comprehensive MEC meetings, trying to move through some policies, and we've had a variety of discussions. I think you will be seeing the results of those discussions soon in future JCC meetings. But because of the robust discussions that they went on, they're not quite ready for presentation. You might have also noticed that we don't have a clinical service report. So a couple of our chiefs had issues away from the hospital that they needed to be away for a period of time, and so they asked to defer those reports. So we may be doubling up on reports as we move forward, but we really wanted to be respectful of what they had going on outside the hospital.
surely, Commissioner Green, any?
No, delighted. I wish I could hear your comments on the first. I'll try. I'm going to be in Boston.
Okay, so and I'm pleased to join you at the virtual staff meeting. It's always a pleasure, and it's sad again that we don't get a chance to meet each other, which has always been one of the highlights of having the staff meeting together. So maybe next year we'll be able to do that. I know you're going to have a reception on the top, so I think it's great. You're going to be in the fresh air, and we'll hope it won't be too fresh or too cold. But if it's like today, it should be nice. So if we have no, and we don't, we have no action items, Mark, we can go on to our next item, I think, if Dr. Green had no further comments.
Yes, item 9 is general public comment. And folks in the line, if you'd like to make comment now, this would be on a topic that's not on the agenda. Please do so by pressing *3. *3. Okay, I don't see any hands, Commissioner, so we can move on to a consideration for a closed session.
Okay, is there a motion to go into closed session?
So moved.
And I would second. Is there any public comment?
Folks online, if you'd like to make comment on the consideration for a closed session item 10, please press *3. All right, looks like there's no hands. Everyone, please give me a few seconds to get us over. Okay, everyone, we are now in closed session. The first item will be the credentials report.
Thanks very much. So in addition to the credentials summary report, as usual, and always happy to take questions about that, I wanted to just talk about one new case. So this was a provider who was being reappointed, and as the reappointment packet was being reviewed, it was noted, there's always a question in the reappointment about, whether anyone has any medical conditions that might be relevant to job performance. And we always appreciate when our providers are forthcoming about this, and the provider disclosed that there had been an illness that had a neuromuscular component. And that there had been a medical leave, and that the provider had returned from medical leave. So at the time of reviewing this, it was realized that the provider had come back from medical leave a couple of months before filling out the reappointment paperwork. But that we did not actually have the return to work form from the clinician caring for the provider. And so, we have a policy that if anyone is out for more than 30 days due to illness or injury, upon return to work and caring for patients, that their own provider, it's a short form to fill out, just saying that they are aware of the job that this provider has, and whether there is anything that would prevent that person from doing their job. And so it came up in the credentials committee that this provider does one invasive procedure, renal biopsy. And so although this is a relatively short procedure, there were some concerns. Well, if there was a neuromuscular illness, we probably need to just make sure that there, aren't any reasons for concern. So we just asked the provider to refrain temporarily from performing renal biopsy. Fortunately, none were scheduled, and to make sure that the form was submitted. The form was promptly submitted. There were no restrictions noted, and therefore there were no restrictions placed on this provider. We're very pleased that this provider is doing better and is back at work. But I wanted to bring it up because it was a very helpful opportunity to remind all the service chiefs and to disseminate widely through the departments just a reminder of the policy that if anyone is out for medical or injury related reasons, that they do need that return to work form submitted when they come back. And that was well received. Happy to take any questions if you have any questions about that case or anything else on the credential summary report.
Commissioner Chow, you were speaking, but you were muted, so I unmuted you.
Oh, thank you. It was merely and really to appreciate the report that you gave and to find out if Commissioner Green had any questions.
Oh, thank you. I would move to approve the credentials report.
Okay. Before a second, I would just comment that I thought that the committee really did its work and was quite careful then about following the guideline, which of course was for patient safety, and that you took that opportunity also to remind all of the service chiefs that this is something that needs to be that. Is it 30 days that they're absent or less or?
Yeah, that's correct. It's a 30-day absence. Only the note from the provider is only required if the absence is for illness or injury. But yes, that's the correct timeline.
Okay. With that, then I would also second the report.
Great. So with that action, we can consider it approved, and we can move on to the PIPS minutes report.
Thank you.
I'm not sure who's giving that today.
Who's giving the?
Hi, Mark.
Oh, hi.
I'll be taking it for today. I'm covering for Luke. My privilege. Would you be able to share, or WebEx is a little different?
I'm not able to share in closed session.
Okay. Then I will. You have received the packets, I believe.
I can give you permission to share if you'd like.
No, I think we're good. If you have it, it's fine. I think everybody has received the minutes. I'm coming for Luke John today. He's fortunate to be taking a little bit of time. Reintroduce myself, Dr. Hewen, Associate Chief Medical Officer. I have had the privilege of serving as the interim medical director for Occ Health for the accolades earlier. Here are the PIPS minutes. I think you all have said plenty about occupational health. Just my appreciation to, and I think we all are very appreciative of the more than 200 employees who have stepped away from their day-to-day jobs. Some have stepped away from retirement and come back to work and helping us, and really their service to our colleagues and employees. I just want to thank them. The pictures that I've shared on there, you've got people who've come in as COVID hires. You've got people who are LVNs in RFPC clinic. Rochelle is a 5th floor inpatient nurse. You have people from normal employee health, and I just, they're all smiling, and I didn't make them all smile. But they're all incredibly compassionate, and I've just learned a ton from them. I think we should all be very proud to see how they've all stepped up. It certainly hasn't been smooth. It certainly hasn't been easy. There's been a lot of bumps along the road. They keep getting better. They are in their 6th surge. There are vets in that group who are normally in the dental clinic as anesthesia nurses, right? And they're like, if they ever make a recommendation on what to do with an employee, I always listen to them. I've time and time again, I've learned that they know best. They have plenty of data to back it up, and they get a ton of guidance from infection control. So all credit to the entire organization for supporting them and participating. You'll see that the second point I just want to make is that we are this month we fell a little bit behind on our equity work. We have some action items that we'll be following up on. We have 4 departmental reports that actually did stratify, but we're aiming higher. I believe you all know we're asking them to take active participation in implementing countermeasures to working on equity. So that's the second point. There are a couple of other reports in there. I'll take questions, but I'd like to, I received some questions from Dr. Green. So if you wouldn't mind, I believe there was a question around Code Blue, a couple of them. One is the Zoll contract. So a Zoll contract is simply as an external vendor for our defibrillators. These Zoll machines, my understanding, now have the ability to record data from the Code Blue events. So we don't rely on hunting down pieces of paper where we documented things, including the quality of compressions. Now that data, where it's stored, how we access it and share it, gets a little bit complicated, and it's important for us to make sure that there's confidentiality and privacy on that data. And so that, with data sharing agreements and contracts, is under review. So that's what that is. It's an administrative issue, but it'll allow the team to review cases individually to look at whether or not the outcome was related to challenges during the case. You asked another question around where code blues happen. They've done this previously, so I pulled back reports from last year as an example. The vast majority happen in the ICU. About 40 to 60% in any 6-month period happen in the ICUs, the medical ICU, the surgical ICUs. About 30% happen on the floors, and then about 10% happen in other areas like the OR, the ED, psychiatry, unfortunately, and some other settings. Partly that is because, for instance, in the ICU, and I think you asked a question around drug overdoses. If you're talking about people who are admitted for a drug overdose, they're often intubated in the field and or taken care of by ED doctors, so they don't call a code blue. They're able to muster all the resources they need in an activation that would be part of our normal medical activations. It's pretty rare for a code blue to be called in the ED or the operating room because they usually have the hands, the resources they need. It's usually when they need something like an extra set of hands for airway that they'll call a code blue. So that's pretty limited. I think it looked like maybe 2 a year in the ED, not very often. There was another question you asked about confidentiality and privacy. For occupational health specifically, that I believe, and you can share with me more what you have had at Laguna Honda. We've partnered with them. Most of this has to do with the Epic implementation that started on July 12th, 2021 in the midst of our Delta surge. So we spent many, many months employee health, occupational health. What I have learned as being the medical director for that group is they take their roles in ensuring employee responsibility incredibly highly, at a very high level. They are very mindful of things like workers' comp, OSHA requirements, as well as the normal practices that we have for patient and employee privacy. So I've learned a ton both on how much they're committed to it, as well as some of the potential challenges of being on an EHR that's shared. So I will say that we've implemented, I think at least at last count, 5 additional measures on top of our normal Epic system to ensure privacy. So without getting into too many details, but just a few examples, our whole employee health side lives in a confidential service area. So the data that goes in there doesn't get shared broadly to the rest of the hospital. We originally tried to turn off Care Everywhere, which gives us access for those who've used Epic, seamless access to seeing care in other areas. And so all my 15 patients on the inpatient service today, that's great. When you are giving a flu shot to your colleague and you happen to see that they went to the doctor yesterday without even trying, that can be a challenge, and they've expressed that as well. So as we purged that data the first round, and our IT team then went back 6 months later, and they finally found a way to turn it off, which is, frankly, it's a challenge. It makes it a bigger challenge because that is now the standard when you're trying to get outside records, and we've decided that the risk was not worth the benefit at that point. And so we're working through that. I think we're all still learning. That's just 2 examples of how they're trying to ensure privacy. With that, I think I'll pause for questions. I don't know if there were any other questions on the email. Sorry, I lost my screen.
Commissioners, I've muted both of you, so please unmute yourself if you want to talk. I unmuted you, Dr. Chow. It's okay, you can go ahead.
Okay, I've lost the screen here at the moment. I don't really know what happened to it, but Dr. Green, did you have further questions?
No, I don't think so. Thank you for answering those that I submitted.
I'm actually back to a screen for panelists. I don't know what that's going to do. Do I sign in again, Mark?
Mark, now you're on mute.
Okay.
Dr. Chow, do you have any questions for Dr. Hewen right now? I can talk. I'll call you and we can do that, but I want to make sure that the whole meeting isn't watching us. Help me help you. Do you have anything to ask based on what he just said?
Yeah, I have. It was in regards to the TV compliance. a little surprised it is that, well, actually, it was only for 4 months, so maybe 58%, I guess, is not necessarily bad. But I was trying to understand that in the PPD test, you say that it's a two-step process and now 4 appointments instead of 3. And so not exactly sure because the PP test actually requires only 2 appointments, one for the injection and one maybe 48 hours later, right? Or is this now a more sensitive skin test?
Part of this was these are logistics that are intended actually for new hires. There is a higher bar or that they have been implementing for some time for new hires without previous testing, where they'll not only clear people from a human resources standpoint broadly for infection control, but they'll do a two-step PPD. So so they've figured out some logistics where there was an additional visit that they were using to be able to place the two-step. So they'll place the initial and then they'll place the subsequent. There's going to be an overhaul of our TB screening process that we are partnering with Dr. Winston and others in infection control, where we have held a pretty high standard for the entire campus for annual testing that we think that we can adjust. It requires some updating that it would align us better to things like the CDC, but would actually require a waiver from CDPH, which has not caught up with the CDC requirements or guidelines.
Okay, no, thanks. I understand now that the 4 appointments were really related also to new hires. Okay. So, Mark, we're gonna have to figure out how I get a picture.
Okay, so how about if everyone takes a 30-second breather? I'm going to call Dr. Chow. I'm going to mute both of us. I'm going to call you to pick up your phone, and we'll try to do that. So now everyone is hearing me try to guide you through this. And actually, Susan Brakovich, who should have permission to share the screen? So I'm getting ready for that too.
Mark, I will be sharing the screens tonight.
Okay, great. So I'm going to give you that role right now, and then everyone please have patience as we I figure this out.
Ready. While Mark is assisting Dr. Chow, Dr. Green, can you hear me? I'm just doing a test of my audio.
Yes, I hear you just fine. Thanks.
Great, thank you. I turned off my video just to help support better audio because I was cutting out earlier in a previous meeting.
All right, so it looks like we're back. And before we begin the presentation, commissioners, if you would consider a approval of the PIP's minutes report, that's part of the action that is needed in closed session. And we just finished that before we go into the next item.
So moved.
And I would second that. Happy to see you.
Oh, let's see. I'm sorry. My sound was turned down. Did you two just do it?
Yeah, we just
Okay.
did it. We
All
just
right.
did it.
I apologize. I turned it down so I could listen to Dr. Chow without hearing everything else. Okay, great. Thank you. And Susan and RCA team, please move forward. Thank you all for your patience.
Thank you.
Thank you, Mark. Good evening, commissioners. Today, risk management is here with you not for new cases and no new RCAs, but at the request that you gave us to regarding 2 cases where we presented prior action plans, and you had asked us to come back to answer, have a little more discussion. With me tonight on this first case, and this is unusual because this is a settlement action, is our OB team. Introductions. I saw the team earlier. Kelly, will you take us away? I saw your face on the screen first.
Yes. Hi, I'm Kelly Brandon. I'm the clinical nurse specialist here at the Zuckerberg San Francisco General Hospital Birth Center.
Hi, I'm Eleanor Dry. I'm the OB who's the medical director of inpatient obstetrics and the abortion clinic.
I'm Jessica Rourke, the nurse manager of the birth center.
Thanks, team. So it's unusual, but I brought my partners today because without them, we don't do this work. And this matter is a settlement action whereby to the full commission, we presented a settlement action on an OB birth injury case. Let me advance my slide here to refresh everyone's memory. Ooh, one back. And Dr. Green, you specifically had asked if we could invite our OB partners to talk about this case. This was a case that was presented in August. That occurred in August of 2020. It occurred in OB. There was a patient weeks plus 1 day pregnant, and she had come in for delivery, and there was a deterioration in condition during her delivery. The neonate was born with 0, 0, and 0, and subsequently that neonate had died. There was a settlement paid both by that was shared by UCSF and ZSFG in this matter. And again, the reason we're here today is not to go over not to revisit the settlement, but more importantly to talk about those action items. We identified opportunities in the course of the defense of that case through our experts. And the 3 that were identified from the experts were there were gaps in communication between providers, secondary to some ambiguity of language regarding the decision. Second, there was noted delay in proceeding urgently or emergently from a C-section for the C-section delivery. And again, that was a criticism by the experts. And then thirdly, a lack of documentation to support timely intervention by the care team. So of course, as part of our Plan, Do, Study, Act, the team has been studying the effectiveness of the re-education that we had done as part of our improvement. And we found that there needed to be regarding the grading system because we did see that there was memorization for remembering the grading system. And this is where I defer to the OB experts along with Dr. Green, who's an OB expert, to talk about what those action plans were. I'll highlight them and then I'll open it up for Dr. Have those questions and have our OB team answer any questions you might have. The 3 action items that we talked about at the settlement training regarding decision to incision language, specifically that grading system, and then a worksheet that was created and revised from a numerical grading system to one that had time expectations, a coding system to provide guidelines, which makes it easier for them to remember during high stress clinical decision-making moments. And down below that third box there, you'll see we went, instead of calling it a grade 3, it was changed to a code C, which is moving as fast as possible, what we refer to as that code OB. Grade 2 going from grade 2 to a C 30 minutes. This is again that the time frame, which means you want to get there ASAP, but you're not running down the hall. And so again, I'll stop here before I go to the next. Well, actually, let me do the next slide just to cover all of the actions that we discussed, and then I'll open it up for questions that either of the commissioners may have for our OB team. Additional actions. Once we do once the PDSA is solidified and we've done some training and we've done those simulations, then forward future state into building worksheet elements into EPIC. That's a future state action item. Again, we want to study things before we go right into building an EPIC. We had additionally talked about the need for specific decision to incision simulations as part of the sim drills. And part of that was also the inclusion and participation of the multidisciplinary team, which is the RN, certified nurse midwife, and know that sometimes it starts with the RN and the certified nurse midwife, and then if there's a change, there could be the addition of the OB. We did recognize and want to be transparent with the commissioners that because of COVID, staffing related challenges, and you saw that we've had quite the uptick in OB deliveries. Some of the challenges we've had with staffing is we've had to at times pause or the simulation drills haven't been occurring as frequently because the staffing, the uptick of census, as well as our COVID challenges. I'll stop there and really open it up for conversations that commissioners may have with our OB partners.
So Dr. Green.
Yes, well, first of all, thank you so much for sharing your thoughts. And this kind of an episode is incredibly traumatic for staff, for everyone, family, of course, and I know it weighs very heavily on everyone, and everyone does the best job possible to make sure that corrective action is taken and that you don't have to go through that again. I guess there are two things I always think of in this, and I think your coding system is really appropriate. That makes a lot of sense because I think communication language, we have this problem too, because every now and again, I mean, you guys will all know, you do a delivery, everybody's reporting things, and then suddenly you see this gush of blood. And in an obstetrics unit, it's very difficult. You can't just say, hemorrhage, because you've got family members. And so even as simple as we need to bring the hemorrhage card in is a language issue in an obstetrics unit when you've got observing family as part of the dialogue and how you communicate that. And we've struggled with that. One of the things we came up with was no epic. So if something's going on and you say no epic, it means, hey, look in the field. But this is a real challenge. And I guess the only other thing I would be thinking about in a situation like this is the chain of command, because I see chain of command questions in two ways, and it may be more complicated with what you guys do than where I am, because you have residents and you have people who rotate constantly as opposed to a more stable situation where it's the same people all the time. But every now and again, you as staff will see things on a tracing that you feel is of concern, and the people who are in a position to make that decision to go to incision may not be clear. And then how you run it up the flagpole, because there are times when you see things way before any physician would, much less July when everybody's starting out afresh and is just getting their own orientation. So I'm wondering how you might incorporate how quickly and how you would run up the chain of command if you on the floor, you as staff have concerns, where who's the ultimate top of the chain who can really make that code OB decision on the physician side, and then what about on your nursing side? Do you go through your charge, or how does that work, and is that going to be part of this plan?
Yeah, so I think reformatting the language to be something that folks didn't have to memorize, which was the big finding we had with our previous system, which was a grading system, was the primary finding. But in being able to interview and talk with people more to kind of go through a full PDSA cycle on this process, we discovered that we needed these codes to also be linked with the simple steps that you'll take in each instance on a worksheet. So Our worksheet now includes both, like for the code C, it kind of tells you that you should, the DTI is made for you because the expectation is a maximum of 15 minutes to delivery from incision. But it also has listed out expected actions, which include an immediate escalation on our unit. And it spells that out in a really simplistic way that helps people understand steps. For us on the unit, I think that's twofold. One is activating our code OB. So the code OB is a universal code system that calls a batch of pages that actually gets both the OB attending, the charge nurse for the obstetrical side, but also the charge nurse for the NICU and the NICU attending. So it's our most high level activation that's really simply activated with one call to the operator. And so that is spelled out as that's the expectation to immediately escalate to your most senior staff in those circumstances. And that's listed as a definite action for code Cs. For C30s, our kind of intermediary category, it says that a code OB may be activated, but if you opt not to activate the code OB, it lists out who needs to be called, which is again immediately that jump to our most senior providers. But the second part of that question, I think, really comes with just for myself as a nurse that works on the floor, comes with actually the long-term culture setting on the unit, that each of us feel that we can actually escalate to our most senior staff at any time that we feel that we have any question or even uncomfortable feeling, right? It doesn't even have to be a solid clinical finding. And so I think that that's another piece of this that every organization has to constantly be proactively working toward. And I think that I think we do very well in that area. I think we work very hard to help every team member feel valued and to make them feel that their opinion really does matter for the safety and the best outcomes for every patient. But it takes a lot of work. And you're right, we have so many different personalities and roles rotating through our unit that it's certainly not seamless through every person in every role. So if it's ingrained as an expectation, though, once everyone's here, I think we have the tools to work that out over time. So I think between those two pieces is something that we can really focus on and continue to work on.
Well, thank you so much. I think you said it so eloquently that it really is the culture, and it's a culture that we're looking at in a lot of other ways. See something, say something, and it is that group of people. I mean, the obvious now cases where you crash someone under general are one thing, but the ones where I think we get into trouble are the ones where you can only move as fast as the slowest person. And the other thing, I guess, that really helps thinking through is that balance between documentation and action. In other words, you get in the operating room, someone has to put a bovie pad on, someone has to get the suction ready, someone has to, get the family, someone has to make sure the anesthesiologist is in the room. So, I've just noticed, having been through many of these, how it always takes longer than you think it will. And I know sometimes I'm frustrated because someone needs a Foley put in, and meanwhile, someone's over at Epic, and it's important to document for sure. But I think, in those intermediate cases, or even in the code ones where you can document later, but it's so important to have sometimes all hands on deck, because someone suddenly comes in there with a decel that you've got to act on, and you don't have a Foley, you don't have an IV, you don't have anything, and you have to make sure that as you've said, that there's a division of labor so that every one of those items can be accomplished, and that someone on the nursing side is taking charge of all of those steps that, if you need the whole package, it's a lot. And then someone on the physician side is also, talking about the consent or whatever it takes to get moving. I mean, I'm sure you guys all know that, but I always feel like I haven't quite done it as well as I could have. And I wonder what could be different. And it's just challenging.
Dr. Dry, any comments?
Well, I was just going to say that I really appreciate the new language, in part because it meshes with what our anesthesia colleagues are used to in our main OR, which I think will make a big difference, to have the cultures sort of mesh really well. But I also just wanted to say that we had a patient recently whose case we reviewed, where I think between the door and the baby out as a transfer from another hospital was less than 30 minutes. Patient with no IV, no nothing. And the charge nurse managed to assemble all the teams and decisions happened quickly enough, and that was really impressive. And it was really, 5 nurses, sort of every nurse on, it was really impressive what could be done, with a really, smart charge nurse assembling the right teams.
Yeah,
It's a good it's a good example of us getting to see real life practice with what we were working on and what we were intending to improve, right? So in the case that Dr. Dry just mentioned, it was actually the nurse that identified the need for a code C and actually called the code OB without a surgeon present, which is, we're in our working environment, we're very used to having our doctors just by our side all the time. So sometimes it can be hard for the nurse to take that step. But I think that, it's really showing that we're working hard on empowering every employee to be able to make that call.
That is wonderful. Do you have a cadre of charge nurses, or do they rotate a lot? Because that's another area that I think is a struggle. And if there's a certain number of people who are especially trained in that position as opposed to random rotation.
No, we have a set number of trained charge nurses that do that role. They also, we have enough per shift where maybe approximately half their shifts are on the floor, the other half are as charge. So they get to keep fresh on the perspective of the role that they're in charge of as well. But it is a set group that gets set training and separate sets of messages and things to be able to help manage the floor.
That's wonderful. They do set the culture, and we used to have like any willing provider, and they changed it about a year and a half ago, and you can really see the difference in all the things you're talking about. It sounds like you've done a great job here, and that this is really well thought out, and I think considers any and all eventualities. And as you said, the key is the culture, that everybody's opinion counts, and no one should feel bashful about speaking up in an obstetrics unit.
Yeah, I think that's our
Dr.
forever goal of improvement, but I think giving people the language to use in the moment is going to be really helpful. And especially now that we discovered that it really needs to have an element of non-memorization. So yeah, we're excited about these changes.
Great, thank you. Thanks so much.
I just want to remind the commissioners, a few years ago now, with some research grant money that was provided by UCSF, the OB team went through Team Steps communication training, which is some of the best practice for teamwork and being able to escalate and chain of command and communicate. And I know that that was done by all members of the OB team, and so that was before this event happened. So this is just building upon that teamwork approach that they added to and complemented with the Team Steps training.
Great. Yeah, that's very effective. It's fun, actually.
Commissioner Chow or Dr. Green, did you have any other questions? Again, this is unusual, but you had asked us to talk about it and hear from our OB partners. So before we move on to the next one, did you have any final questions?
Right. I don't know if Dr. Green was satisfied. Well, it sounds like she's more than satisfied. I guess my questions were, well, first of all, thank you for the follow-up, because it really is important, I think. And now that you had given a quick summary of the case, I think we now remember why we wanted to do a follow-up, because this was really a possible teaching moment for all of us, with using, unfortunately, a very tragic end. So my questions are: one, how long has this been in place? And it sounds like you had an incident recently, but how often has this been used? And I guess I'm still, because I'm not in the OB room like Dr. Green is, trying to understand the idea, of course, of anyone who sees something could say, I guess, all the way from code OB to code 90 minutes. Is that the way it works? And then the most senior person there confirms, or is it that Well, that'd be the only way that could work, right?
We have an accompanying process. So I can say we first started actually using the grading system that where we replaced the language recently, but we used the grading system starting in May of 2016 was when we first started talking about the idea that we needed to have a decision to incision meeting that would establish a time that it's been decided that a C-section will occur, and this is our goal incision time. And so we haven't changed the process of how the decision is made. So for code Cs, the most urgent of cases, then any team member could call a code OB. That's the batch pager system. And once the team is assembled, a decision to proceed would be made by the most senior provider in the room, the OB attending. Every decision to incision that has a lesser time, or if it's an unclear situation, then a decision to incision meeting is called, and there's actually a script for that meeting to be held. It's supposed to be a couple minute meeting where quickly the patient's clinical scenario is discussed and full identification is made, and then at that time the most senior surgeon, the attending would assign we used to say grade, right? But now would assign either C30, C60, C90, or code C to the clinical scenario. And then at that time, there's a quick checklist to go down. Is there any special equipment needed in the operating room? Do second IVs need to be put in place? And if we're not leaving for the operating room right then, what is our planned in-room time to help us accomplish that incision time? And so after running through that quick meeting, everyone has their expected timeframes to get their own role completed by kind of like the due time. We have unscheduled C-sections on a daily basis. So we get to practice this in real life every day. We hold simulations once a month. And our simulation program is really rigorous and involves every interdisciplinary team member on our team. So we get to practice with such scenarios at least once a month. And in that case, there's 12 employees involved in that simulation. And it includes our obstetrical team, our midwifery team, our nursing team, our anesthesia colleagues, and in some instances, our NICU team. And so we have many ways to practice in both real life and also in more of an education setting. We put this language into like rigorous use around January, forgetting which date, just around January. We were developing all of our documents at the end of 2021. Did I miss any part of your question?
No, that was really very helpful, and appreciate the thoughtfulness and the continued education that is occurring, which should help in making the right decision for our patients. So thank you very much. I appreciate the explanation.
Dr. Green, do you have any final questions for our OB team?
No, thank you. This was really very good. Thank you so much.
Thank you all, and thank you for coming. We really appreciate, again, this is unusual that we bring these cases, but OB cases are always high risk, high severity. And so I think focusing and always revisiting the action items are good for discussion and understanding so that we're on point. So thank you again for joining us. And the three of you are excused. We got one more case. You don't have to stick around for that one. All right, commissioners, I have one more case that that's not the case. I have one more case I want to present us in risk management to bring a second case back to this committee just as a return visit. This was from an easy RCA event that we in fact presented to you. We skipped a month, but prior to that we had brought the case. So to recap and to refresh your memory, this was a procedure on an incorrect patient. This occurred in January of 2022, and if you recall, it was a procedure on an incorrect patient, laser eye surgery. This occurred in our 4M specialty clinic whereby a 79-year-old Hispanic Spanish-speaking female had come in, and there were 2 patients with the same last name, and one person answered, and it was not the patient who was the procedure that was intended for, and ultimately she had received an unintended procedure, and the correct patient did get her procedure as well, and disclosure was provided. So this was a sentinel event. We did review the root cause and shared with you earlier that we found that there was a passive patient identification system instead of active patient identification during the final stop before the procedure, which led to the mix-up or the undetection of who was in the procedural chair, and it resulted in the right procedure being done on the wrong patient. So we wanted to come back and share with you our actions, and we're delighted. This was a lot of work by many people. Of course, education is something we always do. So there was a lot of education and shared learning, and we shared the learning with more than one. So nursing isn't here to take the applause for Rosalie, who is over the ambulatory care, and she went ahead and shared this with all the clinics because they do timeouts in more than one place. And then for the actual clinic, there was definite focused education on each member of the clinic doing positive identification and timeout, and the expectation that there would be no other activity during timeout, because in this during the timeout, the provider was busy assembling equipment, and so they weren't all stopping what they were doing. And so for that clinic, we emphasized that it is a timeout moment for the 2 minutes or less that it takes to complete the timeout process. The communication, so there is PDSA of the laser surgery schedule by the providers to allow for more time for consultation between attendings and residents, because we did learn that very, very busy clinic, and then with COVID they had some backed up cases. So that is in progress in terms of making adjustments to their schedule. The next action item was the timeout checklist was changed. So keep in mind, education is what we call a lesser action item. A more strong action item is to have a visual cue. So the checklist that they use, that they are reading from, was revised to actually have active patient identification next to the correct patient. So they have correct patient, correct site, correct procedure, and then we actually to do active patient identification, and then we added the scripting. Please state your full name and date of birth, so to lessen the variance. So that was a visual change, and that went into production, and they have been using it. And again, that timeout checklist was rolled out to other clinics besides 4A. Technology, we're really excited about this one because it sometimes takes a little longer than we like to implement some of those hardware changes, and we actually added and expanded ID wristband utility. So in the clinic settings, they were not using ID wristbands. So it was added to outpatient settings after this event in clinics and ambulatory care areas. Doing our monitoring. And so we're delighted to, before I get to the exciting part of where we're at right now, here's a copy of the shared learning bulletin. One of the changes we made in risk management was the shared learning bulletin gets disseminated to all the physicians, all the residents, and throughout nursing or whatever involved unit, including the involved unit. And we make it available on the risk management share page so that if folks want to go back and look at some shared learning bulletin as new staff come on, that they've got a resource to get those bulletins even after events have occurred. Lastly, and this is where my delight is, when you always want to monitor for effectiveness. How well are your action plans? Are we preventing reoccurrence? And so we are at, we have just completed 60 days, and we had 100% for the first month. We had 94% the second month, and you can see the trend line has just gone from not doing it the way we had our expectations all the way to sitting here in the green, which is where we are expecting our staff to perform timeouts following the script, following the checklist. So any questions about this case? This was one that you were particularly interested in, to see how our actions were resulting in outcome.
So,
Commissioners, oh, there we are.
right, thank you, Dr. Green.
Oh, this is terrific. I think you found great solutions here, and the fact that you socialized it across the system is great.
Right, I think also that that's what we were looking for in terms of report, and probably even beyond that, because you have wonderful uptake and have at least for those for the month that you've been scoring a complete change in the use of the timeout, which looks like that is and you've implemented the octave identification process. On the wristbands, are you using that for people who have procedures, or that's for anyone coming in?
That's a great question that I will find out. I know they were expanding it. I know procedurally anyone who is scheduled for a procedure gets a wristband. I'm not entirely sure, but I will find out for you. That's a great question. Every patient who's being seen, because our clinic volumes are quite high, and I'm not entirely sure if that expansion was only for patients who are getting procedures, but I'll look into that.
Right. I mean, certainly those getting procedures are the highest priority. It wouldn't surprise me that regular clinic visits might not, but really appreciate the swiftness in which you've all responded and the very positive results that you've gotten. So thank you very much for this follow-up.
Great. Thank you. Mark, I've gone ahead and moved to stop sharing, and we don't have any other new cases from any new RCAs this month for the commission. So that concludes the risk management follow-up update.
Thank you so much for that robust discussion. That also concludes the closed session business, Commissioner. So would you please consider a motion to go back into open session?
Move to go back into open session.
Okay, and I would second that.
Great. Please give me a few seconds to get us back there. Okay, we are back into open.
Okay.